basics. So this back to basics is for particularly useful for everyone. That the foundation you need is required to do anything, and if the foundation is good, then you have half done, and you have won the half of the race. So this particular webinar is focused on cerebellopontine angle surgery and its anatomy. And please mute your mic when you are not talking. So this is very complex and challenging area in the brain. And over past few decades, we have seen drastic change in the management protocols about CP angle tumor and their results because of better anesthesia, better positioning, better instruments, better microsurgical techniques, and better understanding, better imaging. The results have been fantastic. So today, I am not going to go into the details of it, as the speakers will talk about the details. I'll just introduce panelist Suresh Bapu, who is very short in height, but he is very has a very high stature, and he did his neurosurgery from Madurai along with our beloved friend Dr. Suresh Nair from Madurai. They were together in early 80s, and after that he was in the medical college at Chennai, and then now he's in practice. He was trained the microneurosurgery with Professor Yasser Gill. Our three speakers will be introduced by the panelists, Dr. Adesh, Dr. Mathew Abraham, and Professor Atul Goel. I'll introduce our other moderator, Dr. Harshad Parekh, who did his MCH from Grand Medical College, JJ Hospital, and then he went to Preston in UK for 2 years. And after that, for last 30 years, he's practicing in Mumbai, particularly in Nanavati Hospital and other attached hospitals. So Dr. Harshad Parekh, I invite you to introduce the panelists, Dr. Tripathy and Professor Turel. Harshad, have you joined? I think he doesn't have the link. So let me hello?
Yes, joined, sir. Yes.
Joined? Okay.
Yes, yes.
Harshad, Harshad,
yes, I'm there. Yes, now I can.
Please introduce
yes.
the panelist.
Yes,
Doctor.
it's my privilege to be part of this webinar. And when Dr. Bhartiya told me about this webinar, it's an excellent webinar to be heard and learned from this panelist and from the moderate other speakers. Today's moderators are our first is Suresh Bapu, one of the most pioneers in microneurosurgery in the country, who started microsurgical procedure very early in the South after getting trained by Professor Yasser Gill. He has also served as a professor of neurosurgery in Madras Medical College, and presently he is director of neurosurgery SIMS Chennai. The second moderator is panelist is my good friend Dr. Keki Turel, who is presently the head of neurosurgery at Manipal Hospital, Calcutta, and he was organizing secretary of NASICO in 2024 and invited many conferences as a faculty and speakers. And the third is my teacher, professor, and the renowned neurosurgeon from the world is Professor Keki Turel, who is who was a past president of Skull-Based Surgery Society and NSI. He was trained under Professor Sami, pioneer in microneurosurgery, active in spreading the new knowledge, and regularly conducts the complications in neurosurgery annually and also in WFNS meetings. Professor, welcome, and I request the speakers please to start.
Let the panelists take over.
Yes.
So that Dr.
Good evening. Good evening to all. I invite Dr. Adesh Srivatsav to give his talk on the anatomical aspects of the cerebellopontine angle, the relevant aspects, and then its approaches. Dr. Adesh Srivatsav is a product of Sri Chitra, and he has received gold medals during his undergraduate curriculum, and then he has received so many awards and fellowships programs. He is really very knowledgeable and well experienced in the CP angle tumors. He has been a good teacher. So he is of course a member of many professional societies nationally and internationally, and his publications is a big list. So I invite him to give his talk now.
Thank you, sir, for that kind introduction. And I think sir, my screen is visible now, no?
Yeah.
So since it's a short talk of just 15 minutes, I won't waste time. And I would thank the committee for giving me this opportunity to present the relevant microsurgical anatomy of approaches and cisterns of the CP angle. So basically, the idea of this talk is to apprise the residents and young neurosurgeons and to refresh for people like us about the CP angle. Broadly, we'll be covering the boundaries, divisions, and contents of the CP angle, the cisterns and the arachnoidal relationships of the CP angle contents. We'll give some extra time on the anatomy of the 7th and 8th cranial nerves, because vestibular schwannomas being one of the most common pathologies encountered in the CP angle, and the workhorse approach, the retrosigmoid approach. What anatomy do you see and what to expect in the microsurgical anatomy of vestibular schwannoma? 15 minutes seem to be a short time to cover petroclival meningiomas and other pathologies, as well as covering the middle fossa approach, that is anterior petrosectomy or the translabyrinthine approach. So with these outlines, I think this should be enough of a refresher for all of us. So we all know that CP angle is the acoustico-cerebellar recess of the pontomedullary space, which is lined anteriorly by the dura of the posterior fossa, posterior cranial fossa, which is covering the posterior surface of the petrosal bone and the clivus. Posteriorly, it is the margins are the pons and the middle cerebellar peduncle above and by the flocculus below. Above, we can see the 10th and the 5th cranial nerve, and caudally it's the 9th, 10th and 11th cranial nerves. That's the lower cranial nerves. Yeah. So this CP angle is actually a region. It's a triangular or pyramidal region, which is where the petrosal surface of the cerebellum will wrap around the pons, as seen is in this cadaveric diagram, and the upper medulla, with the middle cerebellar peduncle forming the floor. This angle is formed by the superior and inferior limbs of the cerebellopontine fissures. The apex being laterally over here, and the fissure opening, the base being in the medial portion. Next. So these two pictures are there. If one can see carefully on the left hand side, we see the picture of the CP angle as seen in the retrosigmoid approach, and we are seeing a little bit more inferiorly, as if we have also removed the foramen magnum region, the foramen magnum rim. Sorry. So with this, you can see that on the top is the fifth cranial nerve, and at the bottom part is the jugular foramen, wherein the lower cranial nerves are entering. The medial most portion, one can appreciate the 12th cranial nerve going, and the middle part of it is the 7th and 8th cranial nerve complex going into the internal auditory meatus. This, when seen medially, anteromedially, like as if you are looking at it from the region of the upper clivus, maybe between the posterior clinoids, you are looking down into the CP angle, and one has removed the fifth and the third cranial nerve. So again, the 7th, 8th nerve complex can be appreciated in the upper portion. Then you have the jugular foramen, wherein the lower cranial nerves are moving, and the 12th cranial nerve, the basilar artery, which actually is more of a retroclival component, and the 6th cranial nerve is also seen, with the superior vessel as the SCA, the middle vessel as the ICA, and the inferior vessel as the PICA. Now coming to, before describing the divisions of the CP angle, just a brief overview of the various cisterns that can be accessed, and the anatomy of which is very relevant to a microneurosurgeon who wishes to operate in the CP angle. So it is basically constituted by the cerebellopontine and the cerebellomedullary cisterns, and they are separated by the lateral pontomedullary membrane. Medially, one can appreciate the cerebellopontine cistern, which is separated from the prepontine cistern, that's the prepontine cistern, by the anterior pontine membrane. Then we have the cerebellomedullary cistern, and it is separated by trabeculae in front from the lower cranial nerves. So superiorly, we have the cerebellopontine cistern is separated by a superior membrane from the ambient cistern. More medially is the interpeduncular cistern, and posteriorly is the quadrigeminal cistern, which Professor Goel will be touching upon as he explains the supracerebellar approach to the CP angle. And obviously, posteriorly, we had the cisterna magna, which is also very important for surgery in the posterior fossa, because we all access it and drain the CSF through it to relax the cerebellum. Now coming to the divisions of the CP angle. The anatomy can be conceptualized here by breaking down the various neurovascular elements into 3 complexes, and each complex containing one artery and one group of cranial nerves. Like the upper CP angle has the superior cerebellar artery, the middle portion has the ICA, and the inferior portion has the PICA. Similarly, the upper part contains mainly the 5th, 4th, and the 3rd cranial nerves. Now, 3rd and 4th cranial nerves may be a bit superior, may not be considered to be a content of that, but still upper CP angle can be, those nerves can be mentioned. The middle CP angle having the vestibulocochlear nerve, and more medially the abducens nerve. Obviously, the vestibulocochlear nerve has runs along with the facial nerve. That's your 7th, 8th nerve complex. And finally, the lower CP angle, which has the lower cranial nerves going into the jugular foramen. That's your 9th, 10th, and 11th nerve, and the hypoglossal nerve more inferior-medially going into the hypoglossal foramen. This is a view of the superior part of the CP angle, the topmost part, as one can appreciate the tent, the posterior surface of the petrous. And there in the depth, the 5th cranial nerve can be appreciated. The 4th cranial nerve moves along the, wraps around the midbrain, and then along the border of the tentorial notch, it moves anteriorly. This is the middle component of the CP angle, which has the 7th and 8th nerve complex along with the anterior inferior cerebellar artery. And finally, this is the lower cranial nerve portion where one can appreciate the 9th, 10th, and 11th cranial nerves going into the jugular foramen, and more medially you have the hypoglossal foramen into which the 12th nerve goes. And obviously there is the pica, which is currently hidden in this case, not seen. That's the again the 7th, 8th nerve complex and the ICA in a case which does not have a pathology per se in this region. So the anatomy may not be that well visible. One can appreciate the internal acoustic meatus and the 7th, 8th nerve complex going in, but the medial portion may not be very well visible. The lower part, in this view, one can appreciate again the 9th, 10th, 11th cranial nerves going into the jugular foramen. It's more of a superior course. And then you have the 12th nerve more medially. You have the vertebral artery and the pica coming out, and a loop of pica can be seen abutting here on the 8th nerve. And above the 8th nerve is the ICA. That's your flocculus, which is an important landmark along with the choroid plexus to find the medial part of the 7th, 8th nerve complex. So coming to the anatomy of the vestibulocochlear nerve complex, this is one of the most commonly encountered region of the CP angle for any neurosurgeon, because the vestibular schwannomas are one of the most common pathologies encountered in the CP angle. Coming to the anatomy and contents of the internal acoustic canal, because this is where the position of the 7th, 8th nerve complex, which is actually 4 different nerves, rather one could say 5 nerves if one includes the nervus intermedius, though it already before entering into the canal or just in the canal, it joins the facial nerve. So you have the facial nerve, you have the superior and inferior vestibular nerve, and you have the cochlear nerve. So the positions of these nerves is most consistent in the meatus. There is a horizontal ridge, which we call as the transverse or a falciform crest in the region of the fundus of the internal auditory meatus, which divides it into an superior and inferior portions. Now the facial and the superior vestibular nerve lie superior to this crest, and the cochlear and the inferior vestibular nerve will lie below them. We'll just see in the next diagram. There's our transverse crest or the falciform ridge that we were talking about, wherein the superior vestibular area, superior vestibular nerve and the facial nerve lies, and then the inferior vestibular nerve and the cochlear nerve lies below the transverse crest. Now there is another vertical ridge of bone in the superior half, which is also called as the vertical crest or the Bill's bar. This separates the facial nerve from the superior vestibular nerve. So the facial nerve occupying the anterosuperior quadrant of the lateral meatus. That's just an endoscopic view of a cadaver, I think. Yeah, where we are seeing the superior vestibular area, the facial canal, the vertical crest, the transverse crest, inferior vestibular area, and the cochlear area. So in this way, actually, the lateral meatus gets divided into 4 portions. Facial nerve taking the anterosuperior, cochlear nerve taking the anteroinferior, and the superior and inferior vestibular nerve taking the posterior part of it. We used to remember it initially in our residency days by using the mnemonic, this diagram of 7 up. That means anteriorly it's 7 up. The 7th nerve lies up. And Coca-Cola, that is the C for cochlear nerve, lies below. And posteriorly you have the superior and inferior vestibular nerves. Now, apart from knowing this anatomy of the nerves, the positions of the relative positions of the nerves in the fundus, one has to also learn how to open up the internal auditory meatus and the fundus in order to address the pathology. That is what we are talking about, the vestibular schwannoma, which is extending into the internal auditory canal. So once the posterior wall has been drilled over here, one can see that there is the nerves are within a dural sheath. So this dural sheath, it attaches then to the perineurium of these nerves later in the course. We'll see that a little bit later. Once the dural sheath has been removed, as can be seen here, so this on this side, one can appreciate that the transverse crest is separating the superior part and the inferior part. In the superior part, posteriorly, we are seeing the superior vestibular nerve, and anteriorly, we are seeing the facial nerve and the nervus intermedius, which is going there. And obviously, here we can see the inferior vestibular nerve, and more anterior to the inferior vestibular nerve is the cochlear nerve. Now, an important part of this drilling, as one does, is one has to realize that lateral to this, more lateral and more anterior to this meatus, lies the labyrinth, that is your semicircular canals, and also the endolymphatic duct and sac. Though endolymphatic duct and sac are a little bit lower, but still, if there is overzealous drilling of the lateral wall of the meatus in order to open the fundus, one can damage the semicircular canals or the endolymphatic duct. So one has to be very careful while drilling. Ideally, the scans for every patient that for whom the drilling is being planned, the pre-operative CT scans, thin CT scans of the temporal bone, or the MRI should be studied well, so that one can decide how much bone can be drilled in order to avoid the semicircular canals. This is another diagram wherein one can appreciate the semicircular canals, the endolymphatic duct and the sac. And an important variation may come sometimes, that when the jugular bulb is a high riding jugular bulb. So it may happen that it may reach near the canal, and one has to again look at this thing in the preoperative scans in order to cause inadvertent injury. This is just an intraoperative representation, endoscopic view, once the canal has been drilled and opened up, and one can appreciate that the seventh nerve, the eighth nerve, the vestibular nerve, the cochlear nerve are nicely demonstrated in this picture. Now, coming to the arachnoidal relationships of the internal auditory canal and the seventh, eighth nerve complex. We know that the CP angle has multiple arachnoidal cisterns. The vestibulo-cochlear cistern is the one that covers the seventh, eighth nerve complex, and its variation into its extension into the meatus is variable. It may end just at the level of the entry of the meatus, or may extend differently for the two nerves, or may even reach up to the fundus, which is often seen as a fundal cap of hyperintensity, which is seen on T2 weighted or your CIS or Fiesta sequence of MRI in cases of vestibular schwannomas, or even in normal patients. Now, the important part of this aspect as to the position of the arachnoid is to decide whether the tumor is an epiarachnoid tumor or a subarachnoid tumor. So there's a lot of debate. Depending upon the extent of the original arachnoidal membrane, the CSF cap on the nerves, and the origin of the tumor may remain extraarachnoid or may become subarachnoid. In either of the case, what is most important, because these are more of retrospective studies or more of pathological studies which have been done after the patients have been operated. So what is important for us to realize over here, that this either single layer or double layer or triple layer of arachnoid which lies over the tumor capsule is actually the layer which will help us in safely peeling off the neurovascular structures which are distorted, stretched, and have become adherent to the tumor. So that fine dissection and peeling off of the arachnoid membrane is most important thing to do. One of the most important things to do. Obviously, that has to be, this reflection has to be done, as we have all learned, that one has to do enough decompression intraoperatively of the tumor before that can be attempted. Another important aspect which comes in the removal of vestibular schwannomas, we studied it from our mentor, Professor Nair, is that the 7th and 8th cranial nerve are actually within the same cistern. There is no arachnoid which separates the 7th and 8th cranial nerve. So, a vestibular schwannoma which arises from the 8th cranial nerve, it directly, that capsule directly, the perineurium directly touches and splays the fibers of the 5th cranial nerve. So often it becomes, the capsule often becomes imperceptible and inseparable from the 7th cranial nerve. Often during decompression, one can see posteriorly, it seems as if there is when majority of the tumor is removed, one can appreciate a cranial nerve which is peeping through an arachnoidal membrane, and one feels, I found the facial nerve, but it's actually behind an arachnoid. So that's not the facial nerve, that's actually your 6th cranial nerve, the abducens nerve that we see. Anyway, moving forward, I think I've already crossed 18 minutes, I'm sorry. Approaches to the CP angle. We have to, there are multiple approaches to the CP angle: the retrosigmoid, the translabyrinthine, the anterior transpetrosal, and the lateral supracerebellar approach. But due to shortage of time, we will be covering here the retrosigmoid approach, which is the workhorse approach, which we use for almost 90% of our cases of CP angle pathologies, be it vestibular schwannomas, petrous meningiomas, petroclival meningiomas, epidermoids, lower cranial schwannomas. So this is the workhorse approach. The positioning is either a park bench position or a supine with head tilt. What we have learned that park bench position though takes a little bit more time, but it avoids kinking of the opposite side jugular veins, and that avoiding of kinking, that free flow diverts the blood from your operative side towards the opposite side. Often if you keep this lateral position, this position supine with a head tilt position, there may be engorgement of veins on the operative side. So the two types of skin incisions which are used, one is the lazy S incision and other is the C incision. Now both of these incisions have their plus and minuses. Now let's first look at the pluses of these incision. The plus of the S-shaped incision is that it, if you have to go more inferiorly, you have to go to the region of the foramen magnum, or there is, you have to take out the foramen magnum rim, you want to drill out the posterior arch of the C1 and mobilize the vertebral artery. So in those cases, the inferior incision for the inferior incision which curves like this towards the midline, we'll be talking about that later, will avoid an injury to the vertebral artery, which can happen in some cases. Whereas with the C-shaped incision, one has to be very careful to avoid that. The advantage of C-shaped incision over the lazy S-shaped incision is this. Because in a C-shaped incision, the whole bulk of the skin and the muscle is reflected anteriorly, that is away from the surgeon. So the depth of operating becomes less as compared to in a lazy S, where equal amount of skin and muscular heaps are created on the side of the surgeon as well as on the opposite side. This also leads to a broader funnel to work, which gives better maneuverability, which is a little bit compromised based upon the S-shaped incision. Both incisions are good. One has to be comfortable in operating. A small word about the lazy S incision as we learned it. So the first thing that you do is you make a line from continuation of the zygomatic arch of the root of the pinna up to the enion. That's your transverse sinus. Then your mastoid tip, a 4 centimeters of the mastoid tip where it meets the transverse sinus, is we consider it as the skin marking for the transverse sigmoid junction. And that's your mastoid. Hello. So that's the mastoid groove region. And the lasius incision is created by making a vertical retroauricular line up to a point, a midpoint between the mastoid tip and the where we are expecting the enion to be. And superiorly, it curves anteriorly towards above the pinna, and inferiorly, from that midpoint, the line midpoint, it goes towards the midline in a lasius fashion in order to avoid the injuring the vertebral artery. That's the lasius incision. So, but nowadays, with the advent of neuronavigation and smaller pathologies being detected, surgeons with advanced skills have now started operating on specific zones rather than opening the whole of the CP angle, maybe superior or middle or inferior. So small incisions are made and small durotomies are made in order to reach the CP angle in the area of interest. Now, after your incision, whether it's a lasius incision or a what you say a C-shaped incision, there are few landmarks which are very important to be identified. The first one is the asterion and the superior nuchal line. Now, the asterion is actually the junction of the parietomastoid, the lambdoid, and the occipitomastoid sutures, and it is said that the asterion is the point where the transverse sigmoid junction is present. Now, it has often been seen, we'll see in the next image, that your transverse...
Dr. Adesh, we are
running short of time.
Can you shorten your presentation?
Yeah, I'll shorten the presentation. So there are two ways. First, you identify the asterion and make a burr hole either in the just below the asterion, and then move inferiorly to create your craniotomy. Or if one wants to be more sure, then make a burr hole near the digastric groove and then go superiorly with your thinning out the bone and nibbler and identify your transverse sigmoid junction and create the craniotomy, retrosigmoid. So I'll skip this one. This is again the same thing. So the neural anatomy as seen through the RMSO approach is once you open it, it's the 7th-8th nerve complex and the inferior cranial nerves and the 5th cranial nerve above. The most important artery which one encounters during the CP angle approach is the ICA and its branches. Obviously, there is SCA above and the pica below, which may not be initially visible to the surgeon while he's operating on a pathology. May be visible for an MVD case, one can appreciate that, but usually not well initially appreciated with a pathology like a vestibular schwannoma or a meningioma. I think I'll skip these. Again, about the venous relationships, there are the veins on the brainstem are actually basically in 4 groups: the pontomedullary, the cerebellomedullary fissure vein, the middle cerebellar peduncle vein, and the cerebellopontine fissure veins. And most of these veins, these 4 groups of veins, join together and reach the superior petrosal sinus above. I think I'll skip because Mathew sir is covering vestibular schwannomas. So I'll skip the anatomy of the vestibular schwannoma. And yeah, I hope that should suffice for this lecture. I've already taken around 25 minutes. Thank you.
Thank you, Dr. Thank you very much, Adesh.
Sir.
The next speaker, Dr. Mathew Abraham. Yeah. Please go ahead. Yeah.
I will introduce. Hi, Dr. Bapu. Hi, everyone. Good evening. Sorry, I'm a little bit different place from my normal place. So it is a pleasure to join everyone in this. Sorry for my background. This lovely seminar just and to see everyone here, all the stalwarts of neurosurgery. And this evening, such a very interesting talk on CP angle. And it's a great pleasure on my behalf and an honor to introduce my friend, Dr. Mathew Abraham, who doesn't need any introduction to this gathering of neurosurgeons of India. But for formality, Mathew has been head of the department of Sri Chitra Tirunal Institute in Tiruvannamalai, and now he's joined a private hospital after relinquishing the Sri Chitra in this Lisi Hospital in Ernakulam. He's the head of neurosurgery, and we know his contribution to the Indian neurosurgery, especially with his special interest to vascular neurosurgery. Wonderful talks by him in various forums, various national, international meetings. There have been, the pleasure of listening to him. And he's also got interest in skull base, as we know, and that is the talk for today. And also, in addition to that, he's very much involved in surgery of the pituitary, the intraventricular lesions, and of course, epilepsy, and so many other super specialties of neurosurgery itself. So, Mathew, it's a great pleasure to listen to you and introduce to you. So, let's hear from you. And Mathew is going to talk to us about surgical strategy in managing common CP angle lesions. Mathew, please.
Thank you so much, Tripathy sir, for such a kind introduction. First of all, let me thank the society, particularly Dr. Roopesh, for giving me this opportunity. First of all, for want of time, I think I will limit my talk mainly to vestibular schwannomas, because I feel surgery for the vestibular schwannoma actually is a procedure which makes you thorough with the entire CP. It is perhaps the most complex of the CP angle. And if you can do a vestibular schwannoma, the other lesions may appear reasonably simple. Okay, so surgery. I'll basically in this talk I will talk basically about approach and technique. 85% of all CP angle tumors are vestibular schwannomas, and over 90% arise from the inferior vestibular nerve. We all know it arises from the Obersteiner Redlich zone. There is around approximately 1 centimeter length from the brainstem, where the peripheral myelin and the central myelin interact, transform. For the other cranial nerves, it's just 1 millimeter, but for the inferior vestibular nerve, it is a prolonged segment. And now the vestibular schwannoma surgery is not seen as purely as a procedure to save life. It is currently a procedure to preserve function and quality of life, besides oncological control. And surgery is no longer the only option, but remains the gold standard. There are certain special concerns for the lesion. It's never a surfacing lesion. It's a deeply located within the bone and partially within the bone. It is intimately associated with the brainstem. It's under cover of the cerebellum. So it is something which is a deep set lesion. You open there, you don't see it. It is always under cover. It is tightly draped by the cochlear and the seventh nerves. And in the very adjacent cistern, you have perhaps the most important of the cranial nerves, that is the lower cranial nerves. The lower cranial nerves is, I will say, it preserves life. The trigeminal nerve is in close approximation with larger nerves. It is highly vascular. It has its own blood supply from the IAM, and it's one of the most vascular lesions you can find in the brain. Basically, there are 3 trajectories when you approach a vestibular schwannoma. There is a retromastoid, a middle fossa, and a transient. And when it comes to the electrophysiology, the 7th nerve you have to protect with continuous EMG and maybe intermittent stimulation, and the 8th nerve with brainstem auditory responses. What about the other nerves of the area? We may think that you have to monitor the lower cranial nerve, the 5th nerve, but actually it is the 7th nerve. And why do you ever monitor? you monitor it to reduce your work, to emphasize on the dissection. And if you monitor too many nerves, the clutter will take your emphasis away from protecting the seventh nerve. And a surgeon who can protect the seventh nerve, which is closely bound without arachnoid to vestibular schwannoma, can with ease protect the other cranial nerves. First of all, the first and the most popular trajectory, that is the retromastoid or the posterolateral trajectory. Already Adesh has given a lot of details. I just wanted to re-emphasize the importance of the asterion. The asterion, we can see, is a point where the peritomastoid, the lambdoid, and the occipitomastoid sutures meet. This is just at the lower border of the transverse and the sigmoid sinus, the confluence. So the first burr hole has to go there, and the craniotomy is centered around this thing. If these sutures are not visible, you have to remember that it is just below the line along the just above the external auditory meatus and along the zygoma. If you draw a line along the zygoma, it will just lie below it. So this landmark is very important to create the initial craniotomy. And after the initial craniotomy is made, you can drill the edges with a diamond and extend it to expose the limits of your craniotomy, that is the transverse sinus and the sigmoid sinus. Going beyond the transverse sinus and sigmoid sinus for most purposes is not useful. So exposing a reasonable amount of the transverse sinus and the sigmoid sinus is sufficient to do a proper surgery. So finding the asterion is the key when it comes to the exposure. The approach gives you a panoramic view. You can see the entire CT angle. It is the best opportunity for preserving all the nerves because none of the nerves are affected during the exposure. However, the problem is the cerebellum. The main victim of a retromastoid approach, particularly in a full brain, is the cerebellum. It is good for any type of tumor, whether it's a small or a big, highly vascular, or when you need to preserve nerves, if it is a bilateral lesion where you just go for a decompression. For all these circumstances, the retromastoid approach is effective. I shall go briefly into the translabyrinthine approach. You land directly on the lesion. For those who do not want to mess around with the cerebellum and perhaps even the brainstem, this is the approach. You can deal with any lesion, any size lesion through this approach. However, the seventh nerve is under greater risk, mainly because of vascular injury. So basically, this is an approach to protect the cerebellum. If you do not want to injure the cerebellum, you directly land on the tumor. And once the tumor has been decompressed, you can actually dissect it off from the cerebellum. The middle fossa approach is basically for the small tumors. Here again, this is a situation where your emphasis is on hearing research, where the location of the tumor will be such that the auditory nerve is away from you. It's behind the tumor. But the problem is the seventh nerve comes as a sandwich from your drilling surface to the tumor in front. So it's a comparatively higher risk for the seventh nerve, but usually it is done only for very, very particularly small intra-canalicular lesions. So the effect on the seventh nerve is likely to be less. So here the anatomy focuses around two aspects. That is, you have to find the greater superficial pectoral nerve and the arcuate eminence. The arcuate eminence is a marker for the superior semicircular canal. So you can find, I hope my pointer is visible. There is a triangle here, and there's a bifurcation on the triangle. If you go along the midline of the triangle, you can and expose the very edge of the pictures. This is the line of the internal auditory canal, and you can drill that and expose it. You should not enter the cochlear nerve, the cochlea. The cochlea is not usually entered, it's a slightly deeper structure. But if you venture more anteriorly against the arcuate eminence, you can easily destroy the superior semicircular canal. My experience in this approach is comparatively limited. I've done only 3 cases, but it was reasonably easy to approach this. One has to remember to retract the dura to the very edge of the pictus, and start drilling from the edge posteriorly, because otherwise you may lose your way. And the initial appearance of the internal auditory meatus, the sleeve of the internal auditory meatus is reassured when you track it posterior. If you start from posterior, there is a small, from the apex of the triangle, you are likely to enter the superior semicircular canal more easily. The next approach, I shall now go into the detail of the retrosigmoid approach, because that is the main workhorse, and perhaps I will demonstrate the technique for operating on a vestibular schwannoma through a retrosigmoid approach. It is basically, we are going back to basics. This is very, it may appear elementary for the highly experienced surgeons, but for the this talk, perhaps I would like to focus on a relatively junior group of neurosurgeons. My technique is basically, I follow the Professor Suresh Bapu's technique, where the patient is kept supine. I do not follow the sitting. The sitting approach has some advantages of blood draining off, and it's like an assistant. But the strain on your arm is higher, and maybe for some people it is okay with armrest. But I found the sitting approach relatively strenuous for a prolonged procedure. The supine approach can have a park bend as well as a lateral head turning, as Adesh had mentioned. I have always felt the park bends to be a little more advantageous. It gives you greater space. The trajectory appears to be wider, and the brain is maybe a little less full, as the venous pressure appears to be less. The position has to be comfortable, just like you should remember that it's like somebody comfortably lying on a park bench. It must not be stressed. I always go for some form of CSF drainage from the lumbar CSF spaces. I find it, the vestibular schwannoma creates some anxiety in the very beginning of your surgery because of full cerebellum. CSF drainage often gives you some relief. The emphasis on the inner arachnoid plane. The Professor Suresh always says that how much you dissect, there will be one more plane inside. It is that which is perhaps most important. All your safety lies in going through the inner arachnoid plane, which is very close. I shall demonstrate that very soon. Drilling of the IAM to reach the fundus. The IAM usually has around 9 millimeter length. When the length is a little more than 10 millimeters, it's very difficult to reach the fundus. The dissection has to be basically multi-directional. You should not dissect through one edge to take the tumor out. Intraoperative monitoring, in my opinion, should be limited to the 7th and 8th nerves. And the nerve must not face any form of linear traction. It must be transverse dissection. And a cautery must be used first. If you're scared of bleeding, this is not a great surgery for you. And the vestibular schwannomas are highly vascular, and your bleeding tolerance needs to be high. And if you're very much cauterizing all the time, there's a good chance that you may injure the nerves. So this is already this craniotomy has been done. A retromastoid craniotomy has been done. And the first step, I'm going to let out CSF. The pleasant sight of the CSF being drained from the CT angle cistern. I seldom go to the foramen magnum region. I'll go from the cistern, usually adjacent to the lower cranial nerves, the CT angle cistern itself. The lax brain. This is actually a 3.5 centimeter lesion. When you can see the arachnoid, you can use a fine tooth forceps. Professor Nair used to have a very fine bioneted tooth forceps, which he always emphasized on the inner arachnoid plane. If you are seeing a blood vessel always your plane will be deeper. All your safety in a vestibular schwannoma lies in going the right plane. So if a shoulder of the arachnoid is visible, you can always use a tooth forceps. So once you have exposed some degree of the vestibular tumor, you can go for internal decompression. You can see the highly vascular lesion. The CUSA is an invaluable tool. Steady decompression. The CT angle, the vestibular schwannoma can be of different consistencies. It may be sometimes quite firm. You're very fortunate if the edge is strong and your assistant can hold the edge. If it is very flimsy, your assistant has to be particularly skilled, or you may have to do the entire procedure without somebody holding the edge, which may perhaps increase time duration costly. You can see once a shoulder is available, for the arachnoid, you can grip it. But it's not possible. As you go deeper, this dissection becomes more difficult. It's not from one plane that you should dissect, one direction. You should gradually develop into the other areas. You can see I can already see the brainstem. So this is one tool that I very frequently use. It's not, I'm just suggesting this tool. The sharp scissors, curved scissors is one of the gentlest of tools. It can act like a tweezer. It can act like a dissector. And you can get different lengths of instrument. So when the shoulder is not available to grip, this instrument is useful in separating the arachnoid. And again, periodic decompression of the lesion is most important. In no stage should the arachnoid membrane be left. If you leave the arachnoid plane, you are in deep trouble. The deadly structures like the brainstem and the branches of the ICA may come into your field suddenly. If you are sufficiently patient, in almost every patient, there's no patient in whom I think you cannot find their arachnoid. If in a circumstance where the tumor is extremely soft, as it has occurred in a few patients, in such a circumstance, it may be safe to remain within the tumor rather than, rarely you may find an extremely soft tumor which does not yield any arachnoid. Every vestibular schwannoma appears to be different. Their texture is different, vascularity is different, the arachnoid adhesions are different, and each is a novel experience. So you can see I'm not using any monitoring tool now. I'm just going for the arachnoid layer as my only guide. As soon as I get some arachnoid plane, I secure it with some little bit of cotton. And again, the decompression continues. Once I have got a very lax membrane-like tumor left, I will pack it with Surgicel. Surgicel is a wonderful tool. Most of the cottons will be removed and replaced with, again, Surgicel. And irrigate with warm saline for a while, maybe a couple of minutes. You get good hemostasis. At this point, the emphasis turns towards the seventh nerve. The seventh nerve can take different forms. You can have a well-rounded, well-formed seventh nerve that's very rare. It's often you may not get it even for a 1.5 centimeter tumor. It's very rare, particularly only 3.4% of the seventh nerve would be rounded. Majority of them will be flattened. And in India, perhaps with this large and giant tumors taking the largest number, statistically forming the largest group, you'll find most of them are membranoid. That is almost like a membrane, forming a draping on the surface of the tumor. In a small group of ones, there is around 1.7%. It may go directly through the tumor. This is sometimes seen in NF2 patients, where the multiple nodules will encircle the seventh nerve. And rarely, this is a deadly form where you'll find the seventh nerve dividing into several groups, several bundles, and going into the here. In this circumstance, with a total excision, are likely to get a deficit. It is unlikely that you will preserve the finer branches of the seventh nerve with any form of dissection. So this is the basically the technique for the IAM drilling and the seventh nerve dissection. Easily separated, cutting the dura on the edge. The diamond drill is one of the safest tools in neurosurgery. The juniors can practice drilling their nails with the diamond drill, and you'll know how safe and how controlled it is. You can drill against the carotid with great safety. Only thing, you should have a pen grip. Drilling up to the fundus, you can see the tumor is already exposed. Drilling up to the fundus is not always straightforward. If vestibular schwannoma extends deep into, the different shapes are there. You can have a funnel shape, you can have a cylindrical shape. So you can see I'm hooking out the tumor from the IAM. This is possible in approximately 2/3 of patients. In around, I found statistically that in approximately 15% of IAMs, it is very difficult to reach the apex and separate this thing from the apex of the tumor from the apex of the IAM. In which case, you may have to leave a small bit at the tip. You can see that it's flattened out like a membrane. This is a 3.8 centimeter tumor. It's not just flattened, it seems to be like a membrane. I'm not at this stage attempting to separate any other nerves. All that can be preserved from the tumor is being preserved. Again, the sharp scissors used like a tweezer can be very helpful. The emphasis on periodic decompression. Like my mentor says that, Professor Suresh says that as you decompress, the whole scenario becomes simpler. This is a lower cranial nerve being protected. The lower cranial nerve is perhaps the most important nerve among the cranial nerves. If you lose it, the patient can die. But it's reasonably straightforward because it's in a cistern outside it. Now, we are the emphasis is going from different directions rather than from one convenient point. If you go from one trajectory, you are likely to give traction on the nerve and produce damage. So as you progress, you have to change your trajectory and go to a different direction of dissection. You rather dissect the tumor away from the structures rather than the structures away from the tumor. Professor Nair always says that it is the brain that you dissect away from the tumor, not the other. So finally, this is the final stages. You can see all your coagulation must be, if possible, limited to the last stages of tumor removal or after. If you have an emphasis, if you're afraid of blood, I'm just stimulating to see. A monopolar stimulator may be better, sometimes in most circumstances, but the bipolar is a gentler tool. So there is a total excision. Here the nerve is flattened and taking an odd angle. The various angles the seventh nerve can take is humongous and can always be misleading. So this is, I made an outcome analysis of my personal series over 3 years. That is 162 cases from a period of August 2017 to August 2020. To see the reality behind seventh nerve preservation, functional preservation, and tumor excision. Of this, probably because it's an institution like Chitra, there is a paucity of smaller tumors. Less than 30 millimeters have been 22, more than 30 millimeters, 134. More than 40 millimeters, the giant lesions have been 109. And the mean size was 46 millimeters and the median was 45 millimeters. So the average tumor that we dealt with was a large one. We all know the degree of strain of a larger tumor is more difficult. Anatomical preservation of the seventh nerve was possible in 144 patients, that is 88.8, irrespective of the size. The anatomical and electrophysiological preservation was possible in 126, that is 77.7 patients. Overall, in lesions less than 30 millimeters, 100%. The seventh nerve functional preservation overall, however, has not been that great in the overall series. At least house fragment grade 3 has been got in 73, that is 46%. And when it is less than 30 millimeters, it has been 82%. So for the larger lesions, you may get more deficits than, and then the smaller lesions are likely to have a grade 3. The mortality was 3%. There is no enhancing tumor in 84%, that is 136 patients. And IAM residual is seen in 13%. I always do the IAM. Every patient that I have operated other than the NF2, I have included the NF2 from the series. And a cisternal residue was seen in 5, that is 3%. Thank you.
That was a great talk, Mathew, and I'm sure everyone really enjoyed the various back to basics points you mentioned. Is basically the exposure, the positioning, and beautiful dissection of the arachnoid plane, preservation of all the nerves, especially seventh nerve, and preservation of the seventh nerve has been very good in your series. And we know Professor Nair's series, very big series from your center, your previous center where you are with Professor Suresh Nair. And I think we will do the discussion, question answer at the end, and I would let somebody introduce Dr. Atul Goel, and a wonderful presentation, Mathew. I really enjoyed all the very important points and fantastic dissection and very good results. Well done.
Thank you.
Professor Turel.
Yes, please. I am already waiting. I hope Atul is joined.
Yeah, very much.
The next speaker is none other than the ubiquitous Dr. Atul Goel. Who does not know him, and I think it will be an utter waste of time trying to introduce him because there's nothing, nobody knows enough about him. What should I say, Atul?
Don't say anything.
There's hundreds of publications, hundreds of different approaches, hundreds of controversies. And his favorite subjects are C1, C2, which everyone knows, and arteriovenous malformations and vestibular schwannomas. What I'm happy to know is that he likes to talk about the lateral supracerebellar approach to the CP angle, which also is one of my favorite approaches long back, though I did not publish it. I presented 3 petroclival meningiomas in a 1992 conference of Skullbase, International Skullbase, on this. So I'm very happy that Atul, you have taken this subject because it has got some uniqueness. This approach has got some uniqueness to CP, especially for petroclival approach, for petroclival tumors. So it's 15 minutes, is that correct?
20 minutes.
20 minutes. All right. Okay. Go ahead. Go ahead.
Okay. So just let me You can see my slides now?
Yes, you can make a full screen if you like.
Just a minute.
Yeah.
So I will be presenting on the petrous apex and the lateral supracerebellar approach. So needless to say that lesions around the petrous apex are amongst the most dangerous, and you can actually do big harm to the patients if you do not understand petrous apex. And this is my personalized story of the last 40 years, which I want to relate, and how I have progressed in the subject of petrous apex. And this was my book in 1996, and I have talked about it many times, how I used to do drilling of the petrous bone, how I used to dissect the carotid and displace anteriorly, displace the ganglion, displace the facial. This is the facial nerve. And lot of petrosectomy was part and parcel of my surgical route in majority of cases in petrous apex. So petrous apex is a complex structure. And if you come from the middle foci, we have discussed last time, there are various important structures like carotid artery, GSPN, Gasserian ganglion, V3, V2, V1, V6th nerve, third nerve, and so many other structures, which are, nobody in the world can do petrous apex resection for petroclival tumors unless he has done real hard work on dissection in the cadaver, dissection all the time, know the anatomy. And I am very proud to see that many young neurosurgeons in India are doing fabulous job, and it only makes me pride, full of pleasure and happiness. And I have dedicated a lot of my initial part of life in dissection. I used to do dissection all the time, demonstrate. I have done several demonstration surgery, dissection on cadavers in Japan, in China, in Korea, in Singapore, and in several parts of our country. So petrous apex is a difficult subject. If you want to understand, this is the heart of a skull-based surgeon. In 1996, about 30 years ago, I described this basal subtemporal approach, basal subtemporal. And here, if you see this picture, for the first time in the literature, in subtemporal approach, I included mastoidectomy in the exposure for petroclival areas. So this mastoidectomy was included for the first time, and you should read this article. And I am, very proud of this article. And this was my exposure for basal temporal, removal of the root of zygoma, roof of condyle, roof of external ear canal, and mastoidectomy to do basal temporal work. And then you get this exposure for the petroclival area. So this was 30 years ago, 1996. And little bit modifications here and there. I did this unique incision. I retracted the temporalis muscle anteriorly, which made zygomatic osteotomy a little bit less required, because if you take the this temporalis muscle anteriorly, you get to the zygoma and then you get a basal exposure. Then my exposures became a little bit restricted and limited. Splitting of the temporalis muscle was another thing that we started doing. Then many of you know we described extradural approach to tumors involving cavernous sinus, tumors involving petroclival area. So this approach for tumors was the first time in the literature. You must see the PubMed. There is no other approach on tumors for extradural approach. So this was one of my powerful approaches. For cavernous hemangioma of cavernous sinus, I have talked about it. Of course, this is middle fossa, and how the dural anatomy can be used, and how these tumors should be removed extradurally. So for cavernous hemangioma, extradural approach was described for the first time in the literature in this article. So and this is anatomical, this is philosophical, these are difficult problems, these are difficult tumors. But fortunate for me that I worked in such an institute where I kept on getting cases after cases and cases after cases, and we reported some years ago 45 cases of cavern, which is the largest series in the world. Then we did basal lateral approach, the approach which I described for trigeminal neurinomas. And then we discussed how these tumors go behind and how you should remove the petrous apex lesion from the middle fossa. So middle fossa was my workhorse. for a number of years, 20 years, 25 years, all majority of cases involving pictoclival tumors. So interdural approach that we described for the first time in the literature for middle fossa part of the tumor, and then we describe interdural approach for extracranial part of the tumor, and then we describe interdural approach for the posterior cranial part of the tumor. So this paper is the most highly cited paper on trigeminal neurinoma, and there are various beautiful things in this paper as to where the trigeminal neurinoma arises, how it extends, and what it does to various cranial nerves. So middle fossa approach was the workhorse for this approach. We also described to minimize infratemporal interdural approach. You can see 30 years ago I described this approach, and people are following this approach in a different pattern using orbital approach and all the maxillary approach to do this interdural. So this was the first article in the literature where we talked of interdural, between the dural layers of cavernous sinus. For extracranial tumor, we described interdural approach to trigeminal neurinomas for V1, V2, V3. And we also, if you read this article carefully, we describe middle fossa, means reverse transcranial approach for removal of extracranial part of this tumor. This paper is also very solid paper, and I wish that you can read this paper. Then we describe middle fossa approach for facial nerve, how to work within the dura and remove. Of course, I am not going to talk too much on these tumors. Now I want to talk about pictoclival tumors. Several years we did this basal temporal craniotomy. This was the article which I published 25-30 years ago, 1999, where we talked about this kind of approach for pictoclival tumors. Retraction of the brain, extradural, intradural, taking a tentorial dural flap. Charlie Drake was the first one for basilar aneurysm. He did middle fossa approach and did this little bit different kind of tentorial incision. We described this kind of tentorial incision to approach the petrous apex in pictoclival meningiomas. Then, of course, we did this. You can imagine this fantastic extension of Kawas's exposure. This is the GSPN. This is the labyrinthine part of the facial nerve, tympanic part, mastoid part. Cut the GSPN, rotate the facial nerve, and then do. So you can imagine middle fossa approach was my hallmark, which I presented all over the world in several lectures and several meetings. And some of these approaches have been very highly cited in the literature. So these kind of tumors, my exposure was middle fossa all the time, and petrosectomy, mobilization of facial nerve, mobilization of carotid artery, mobilization of trigeminal nerve. We learned. I am not saying we became masters. This has to be learned over the process. This has to be acquired. You have to have the technique. You have to have the technology. More than anything else, you have to have the philosophy, which you learn and evolve over the period of time. So these kind of complex tumors, this was removed by me 31 years ago. Can you believe this tumor? This tumor, another one, was removed by me about 30 years ago. This carotid, PCOM, carotid here, basilar here, and extensive petrosectomy was my approach. This was another very beautiful tumor, and posterior clinoid meningiomas, which we have many in numbers, which we removed from the middle fossa. This was the girl I did about 25-30 years ago. She is still alive and fine. This, you see this vascular tumor, the vascularity arises from the posterior wall of the cavernous sinus. At that time, I described that middle fossa approach, get the vascularity and remove this tumor. So this is what I used to do. Now I want to show how I have changed myself for the first time in the literature. And you must see this, nobody can challenge published work. Nobody can challenge. If you want to say this is my approach, you show me the publication. I am saying here is lateral supracerebellar approach to pictoclival meningioma for the first time in the literature 21 years ago. I am not saying posterior conventional approach was described for pictoclival meningioma by Sami. He did it like acoustic tumor. But here we did lateral supracerebellar approach. And believe me, my dear friend, beautiful approach. I can reach the tumor. You see dissection of from middle fossa, the petrous apex drilling and all those things can by itself take quite a bit of 2 hours, 3 hours, and you have to increase the exposure, You have to handle the venous structure, you have to handle the arteries, you have to handle the veins. Here, supracerebellar, you retract the cerebellum, directly hit on the tumor. In 10 minutes, you can be on the tumor. So this supracerebellar approach, as you know, has become quite popular for petroclival meningiomas. So this is the tumor, which is a little bit not exactly petroclival, but this is like an acoustic tumor. The whole world likes to do acoustic tumor by retrosigmoid approach, as we have heard Mathew talking about it. Little bit anterior. Also, there is no need to do petrosectomy and start mobilizing. I used to do all this kind of mobilization. As I have shown you, I described it. But now over the years, I have seen that these kind of tumors, and I don't remember how much time, this also must have been removed 20 years ago. This tumor, in my view, should not take more than half an hour to remove this tumor. If you just go on playing, with the coagulation and all, you may take hours and hours. But this tumor, I don't know how much time I took, but I can see from the feel of this tumor, not more than half an hour. Come from here, identify the fifth nerve early in the operation, get into the tumor, start debulking the tumor, work within the tumor. Don't just work with the bipolar, break the tumor, learn the art of breaking the tumor, break the tumor, then dissect. The most difficult thing in petroclival meningioma and most important thing is to save the sixth nerve which lies anterior in this part. So this is like a regular acoustic which is located a little bit anterior. There's no need to do any kind of petrosectomy. Supracerebellar, come supracerebellar, see the tumor. The fifth nerve will be displaced on the dome of the tumor. Dissect the sixth nerve and attack the tumor. And very quickly, and this tumor also can be done in a very quick fire time. If the tumor is more anterior, like these kind of tumors are the workhorse for middle fossa approach. Majority of people will like to do middle fossa, petrosectomy, Kawase approach. We were doing this all the time earlier, but now, if you ask me, this tumor is a straightforward, simple, very straightforward tumor, quick to be done, rapidly to be done. This is another tumor, more anteriorly. This is for the retrosigmoid supracerebellar approach. Don't come retrosigmoid, because then the facial nerve will come into the picture and other nerves will come into the picture. Get the cisterna magna, retract the brain, push the brain down and get into the tumor and then attack. Attack is the word that you must remember. Even if the tumor is more anterior in this, once if you come from the middle fossa, you don't know what is the consistency, what is the vascularity, and you don't know. Here you come directly see the tumor and then you can start working. So this tumor, for me, now for several years, I will say supracerebellar approach is a beautiful approach. So supracerebellar approach can be done in lateral, can be done in various kinds of position, but sitting position makes it comfortable. I am not saying only sitting, you cannot do in any other position, but sitting makes it comfortable. So get the dandy vein, cut it, and then retract the cerebellum down, and then start working on the tumor. It is such an easy approach, such a quick fire approach that you have to do it to learn to see it. So this is another tumor which has been removed quite beautifully. And over the years, I have got beautiful experience on these tumors. These are some of my very old cases. This tumor, when it goes into the cavernous sinus, my recommendation is you have to understand where it is going. If it is going in the dural cave of the cavernous sinus, you should, okay, but it is going in the confines of the cavernous sinus, venous structure and all, then you have to be a little bit careful from the posterior fossa, particularly in sitting position, you have to avoid. When it goes outside the cavernous sinus, then posterior fossa supracerebellar is quite a straightforward approach. This is another tumor when it goes like this supratentorial. It is outside the confines of cavernous sinus. So come supracerebellar, remove the tumor. You have so much space, cut the tentorium, get the fourth nerve quickly in control, and then start debulking. Learn the art of debulking, learn the art of understanding the tumor and breaking the tumor. So we have done over the years several beautiful cases. This tumor vascularity arising from the posterior wall of the cavernous sinus. These tumors I used to do from the middle fossa all the time, but this has been done from the supracerebellar. Now I have got the hang of this and I can get the vascularity here. Basically, vascularity does not bother me so much more than consistency bothers me a little bit more than vascularity. break the tumor, get the bleeding. And bleeding control is our life. Bleeding control is our most important challenge in neurosurgery. This is another tumor. Vascularity is coming from the cavernous sinus, also done from supracerebellar. Believe me, beautiful approach. Most of the tumors which go into the Meckel's dural cave, like you see here, these are soft tumors. These can be quite beautifully removed. You see this tumor here encasing. Now, if you say, I will come from the middle fossa and break into the tumor and come break the whole bones, I don't think now it is necessary. You see, these tumors, the vessels are very close from the posterior, this territory. From here and here, the distance becomes big and the exposure becomes less and the control becomes less. Most importantly, the sixth nerve control becomes less when you are doing from the middle fossa. And these are the tumors. And here is a little bit of a video if you can see, but unfortunately, I don't think I can show you. But you see from the supracerebellar approach, this tumor has been beautiful. Most dangerous thing in supracerebellar approach or in any approach for petroclival meningioma is the PCOM artery, which sometimes drapes over the dome of the tumor, sometimes traverses the tumor, and you can damage. And if you damage, you can have a bad disaster kind of an outcome in that situation. And from the supracerebellar, you can go. You see, these videos are also very 15 or 20 years old video. And I think what you can appreciate is the exposure which I'm getting, the control that I'm having on the tumor. So this tumor is another big tumor, supracerebellar approach, little bit around the PCOM and the third nerve I have left behind, and we have to follow. You see, you cannot just start jumping with radiation in these tumors or in any tumor. You have to wait, watch, and then think about radiation much later. As long as your knife can work, don't think. You see from the supracerebellar, what a beautiful exposure you are getting from here. And everything under control and everything under beautiful control. These vessels are under control. I am not trying to say about results. I am not talking about this and that. I am trying to say, now this is one tumor. You see from the supracerebellar, if I can show you, you see this basilar, this is vertebral artery, this is basilar artery, how much you can get from the supracerebellar exposure. This is tremendous exposure you can get. If the tumors are low down in the clivus, there is no other approach. There is no question of any other approach. You come from posterior cranial fossa and get, if you start coming from the nose and all, that is a complete disaster right from the beginning. So petroclival meningiomas are difficult problem, dangerous problem. Most important issue is the sixth nerve is in question. Like in this patient, I have left some tumor behind, even when the sixth nerve was already involved. And this patient is now for more than 10 or 15 years, this patient has no recurrence and no improvement and no worsening in any other. She is fine and doing good job. So how much to remove, how much is safe, you learn by experience and you learn. You see this tumor, also quite a firm, bad tumor, basilar artery in case I have removed from the middle fossa this tumor, and quite a bit of tumor I have left behind. So whether you want to remove the whole tumor or not the whole tumor, that is another question. So that is petroclival story, meningioma story. Now I want to talk of chordoma story, which is a very important subject of a skull base. So we described for the first time that chordomas arise from the bone. They displace the soft tissue. They displace the cavernous sinus here. They displace the carotid anteriorly. Another thing that I have recently described is the sixth nerve which traverses in the cavernous sinus along with the carotid artery, takes a divorce from the carotid artery and comes back to its brothers, the other cranial nerves, and is located on the dome of the tumor, the sixth nerve. This tumor, and you remember this, sixth nerve has changed. This will be described recently, this one. So sixth nerve goes on the dome of the tumor. So these tumors, because the carotid is displaced anteriorly, 30 years ago, I described this paper, beautiful paper you must read. Then we described middle fossa approach. This is also still a very fantastic approach because the carotid is anterior, the tumor is soft, the tumor can be debulked quite quickly, and everything under control, the carotid under control, and quick job. You see, this is the carotid. You may not believe, but this tumor I had removed the whole thing, not more than 45 minutes or half an hour. I removed this tumor, soft tumor. How much to clivus to be drilled, how much not to be drilled is another question. So middle fossa approach, see this little bit of an anatomy I'm showing. This is the hole from the middle fossa. You see how much the entire, this is the carotid artery, this is the fifth nerve, everything under complete control. And then you can remove the tumor. These are not difficult. These are soft tumors and you keep on getting. But recently, about 10 years or 7-8 years ago, we described supracerebellar, lateral supracerebellar approach to clival chordoma. You will say, why to do lateral supra? See, this is the tumor. For this tumor, you can come middle fossa. For this tumor, some people will come even from the nose. But you imagine this tumor is majority in the posterior cranial fossa. If you come from here, there will be another layer of dura. The most important thing is the sixth nerve can be very early in your control. If you do supracerebellar approach is quite a viable. I'm not saying the best approach, but to save the sixth nerve. If you come from the nose, the sixth nerve is very remote and it is here. If you come from the lateral, the sixth nerve. But from here, you can come underneath the tumor, identify, break into the tumor, debulk the tumor, identify the sixth nerve, and save the. I'm not saying for all the cases. You must remember, I am now saying these tumors are essentially extradural tumors, and extradural tumors are in the vicinity of the veins. Doing in sitting position can be a little bit dangerous. So these tumors, chordomas in particular, you should do in alternative position, not in sitting position. This is another clival chordoma, supracerebellar, beautiful approach. This is another huge tumor. You see this tumor? You can come from the nose. You can come lateral, middle fossa subjects, the approach which I described, most fantastic middle fossa approach that on the basis of philosophy of the tumor. Imagine you can come from supracerebellar, attack the tumor. These are softest tumor and you can do a very beautiful job. Most important is, and the most critical nerve in this situation is, of course, the carotid arteries thing will be there. But you must remember, carotid arteries outside the confines of the tumor. That has to be remembered. Basilar arteries outside the confines of the tumor. If you know these tumors, if you know that the dura is going to be protecting you, if you know the philosophy of these tumors, these can be removed in a very beautiful way. Now I want to talk of another tumor, which is a absolute, I consider this one of the most underrated paper in the history of neurosurgery. We talked about epidermoid tumors. When we talk of epidermoid tumors, they arise in the region of the tentorium. That is why we label them as tentorial-based epidermoids. We have got a huge series, not one of the largest series in epidermoid tumors, where we said that these tumors are along the tentorium. So if you retract the cerebellum down, you see directly the tumor. And then you start working this, and we call it tentorium-based epidermoid tumor. And supracerebellar approach to epidermoid tumor, not retrosigmoid. Supracerebellar, these are along the tentorium, and these are soft tumors. These are beautiful tumors, but attack is supracerebellar. Start debulking the tumor. Once you debulk the tumor, the whole of tentorium is with you. Then cut the tentorium and attack. I have demonstrated these cases in several workshops when in my hospital, and we have done so many. Supracerebellar approach is the approach for epidermoid tumor as an initial step. Of course, then you work on this. Initial step is supracerebellar, then how you cut the tentorium, and then how you remove the part along the brainstem. So this is the tumor, how you will remove. Not come from the cerebellum, come supracerebellar. Get into the tumor quickly, and then whatever is going in the middle fossa, you remove, and that has to be removed in a beautiful fashion. These tumors are benignest of all tumors. These tumors will give you a beautiful anatomical work, anatomical panoramic view after the resection, and there is no learn the art of breaking epidermoid tumor. If you say I remove the tumor with coagulation and all, you don't know what is neurosurgery. If you say I will start doing this microsurgery and all those things, you have to learn to break in a beautiful subarachnoid path, and you have to remove this tumor in the middle fossa and in the posterior fossa, supracerebellar approach. This is the picture. I don't want to show too much of this because it might take time, but still let me see if You see, this is working over the tentorium. I have cut the tentorium. Then I have gone, I have, done. You will see the pituitary stalk, you will see the carotid artery, you see, you have to only see how to break the tumor. One of the workshop, Lucky Tripathi may remember, I demonstrated from 2nd nerve to 12th nerve in the same exposure for epidermoid tumors. There you have to learn epidermoid tumors. These are beautiful tumors to look at and beautiful tumors to operate, and ultimately most benignest of all tumors. So we have done several of these cases, and I don't want to show. Another beautiful approach that we described is this tumor is completely in the middle fossa. The images you can see that this is epidermoid tumor. For the first time in the literature, we described lateral supracerebellar transtentorial approach for middle fossa tumor. You check the literature, there is not a single approach described before our paper of middle fossa tumor being removed by posterior fossa root node. After that, there are several other papers. People are doing amygdala hippocampeotomy. People are doing medial temporal glioma resection. But for a middle fossa approach, posterior fossa approach, this was the first paper in the literature, and I'm proud about it. And brainstem anatomy has to be learned. Brainstem is a different structure. We have done several anatomical works on white fiber, and you must read my article from the cerebral peduncle, which are the safe areas to operate, and how the fascicles and fibers are displaced. This is tumor which I am removing. I don't want to show too much of this video. This is another tumor where supracerebellar approach. Now you say, I will come from the middle fossa, I will come from anterior fossa. Then this is a lateral supracerebellar approach. Get to the brainstem, identify the best part to attack this tumor. There is a cystic component, then here is a solid component. Identify how to remove, what to do and what not to do, and ultimately you have to do a beautiful job for this tumor. So thank you very much, my dear friends. Supracerebellar approach is quite a beautiful approach. For epidermoid tumor, it is the approach. For selected chordomas, it can be an approach, and for a large number of petroclival meningioma, it can be the selected approach for petroclival meningioma. So thank you very much. Keki, are you lost?
And yes, no, I'm very much for it. As I told you, I did this approach for the first time in 1992. Actually, I did the approach in 1988, 89. But then I presented it in 1992, and I had 3 tumors. One was a petroclival meningioma, 2 meningiomas, and one was a chordoma. But later on, I realized I had not diagnosed chordoma at that time. The problem was that chordoma is extradural tumor. And when you do this operation, you go transdural, you go through the dura, and you are violating the dura. So that's an objection. You cannot violate the dura in a chordoma. You are inviting an extradural chordoma into the intradural space. So that is according to me, I made my own criticism that this was, had I made a diagnosis of chordoma, I may not have done this operation by that route. But I very much like this lateral supracerebellar. I've been doing it for several years, and it has got huge advantages, especially if the meningioma is soft. If the meningioma is firm, then there are some reservations because the space and everything else. Also, if the meningioma is going lower down to the lower cranial nerves, you cannot reach by the lateral supracerebellar approach. Then you have to go by the retrosigmoid by lifting the cerebellum. So going from above, it has a limitation how low you can go in by the lateral supracerebellar. So yes, for epidermoid, you may have to use a endoscope also. It will be advantageous to have endoscope because you know how epidermoids go. They just go into any crevices, any spaces. So you need sometimes nowadays that you have this. In fact, the first time when I did this petroclival and I presented in Osaka, Dr. Akuba invited me, and he said he was, as you know, Dr. Akuba is very much for petrosectomy. He did not like this idea of going lateral supracerebellar. He says you are very lucky because the tumor is soft and therefore you can remove it. So I said, yes, I agree. But this is an avenue, this is an approach. I can avoid doing petrosectomy by doing this route. So I'm fully with you on this issue. And we must be careful to know what is the limitation of this approach also. But chordomas, if I know already a diagnosis before the operation, I would not go, because you have to go through the dural barrier, which is against the philosophy, against the rules, transgressing the dura. So let us go back to the first presentations and let it be moderated and panelized by the earlier moderators and panelists. Thank you.
So it was nice listening to Dr. Adesh Srivatsav. He spoke beautifully on the anatomy. If you want me to add something, now we can. We use this horizontal fissure split technique. So when you do retrosigmoid approach, and if you want to go to the seventh nerve complex at the early stage in a large tumors, now if you do the horizontal fissure, if you split that, it takes directly to us, and we sometimes we use. For the matter of fact, we are using this as a routine for most of the vestibular schwannomas. Now we find that. It is very much easier when you do this horizontal fissure split technique. The other thing which probably will add, Dr. We use intraoperative neuro monitoring for all these patients, and we use facial MEP also for these cases. I know Dr. Atul Goel does these things so simply without even intraoperative neuro monitoring. Dr. Atul, you use intraoperative neuro monitoring for vestibular schwannomas, or you are still not using that?
I'm still not using, to tell you the truth. I'm not using.
That's
But on the other hand, I will not say don't use. Those who want to use, those who are comfortable in using, those who have got, they are evolving in their experience, those who are working on these tumors more. I think it is not a bad idea. I'm not criticizing it. But somehow in my career, I didn't ever have a hang of, but I've used it on some occasion and it does help. I'm not saying. But to answer your question, I didn't use it.
That's very important, because the surgical technique is much more important than any of the adjuncts which we use, except maybe microscope and bipolar coagulation. They form a basics for our neurosurgical procedures. But intraoperative neuromonitoring is, as I said, is a very useful technique. QSA also, no, I rarely use QSA. I use, of course, intraoperative neuromonitoring, but only very rarely I use QSA. Mostly we try to remove it with curettes and the tumor knife. Those things we use it, and we use to remove these tumors. So it was nice listening to Dr. Mathew Abraham, and of course, as usual, Dr. Explosive talk by Atul Goel. Everything was very good. Thank you, Dr. Atul Goel. Thank you, Dr. Mathew Abraham.
Thank you, Suresh. Thank you very much.
Atul.
Yes, Lucky.
Atul, yes. What can I say? Like Dr. Bapu mentioned that, if you have the hands like Atul Goel, you don't need any equipment. And I know that. I know that personally. For last 15 years, I have been with you, seeing you operate, and so many difficult cases you have operated together during our workshops. And as you mentioned fondly, that once you showed 2 to 12 on both sides of a petroclival meningioma, and it looked like as if it was a play. But I know very good surgeons how much time and how much concern they have doing this operation. So you got a pair of magic hands, and of course, veteran surgeons like Dr. Turel, Dr. Bapu, and I think all of you have your own techniques. But and as you rightly said, that monitoring does help, and people who are learning, slowly increasing their experience, should use it. You recommend it, but you don't use it. And Mathew, how beautifully you showed the electroid dissection technique. I was really enjoying it, and that is the trick. But of course, the seven nerve identification, whether you do early or late, it all depends on how the nerve is behaving. Like you mentioned, various types of facial nerves, anatomical, situations during this kind of tumor, especially large ones. And monitoring does help, like I just mentioned. But I think with this evening, we have really gone to the basics of CTM lesions. And I thank, Mathew especially, since I introduced him. But of course, I really enjoyed all the talks. And thank you, Roopesh, also for giving me this opportunity to be in this fantastic meeting. Thank you.
So, is there any time to make some comments? I wish to ask the moderators: is there any time to make any comments, or we are over time?
No, you are welcome, sir.
So, my question is: how good is neuronavigation for posterior fossa lesions? Are people comfortable doing neuronavigation with for posterior fossa lesions? I find it sometimes erroneous, sometimes difficult. So I don't know about that. So that's my one question. But with regard to the asterion, I found it very easy if you can put your finger above the mastoid, just above the mastoid and a little behind it. You will find a small dimple in the skull bone. And if you look at that, that point is the asterion. And you are sure to find your transverse sigmoid junction over there. And so forget all those other iniometal lines and lateral cerebellar line, all those things. But if you put that, if you put your finger over there and feel it, you will be able to you will rarely go wrong in your diagnosis of transverse sigmoid junction. But I must say that it is many people prefer to do a burr and then a craniectomy. There are some who prefer to do a craniotomy. So it all depends upon an individual surgeon whether you would like to do a craniotomy or craniectomy. But even if you're doing a craniotomy, it may be a good idea to stay a millimeter or two away from the sinuses and then nibble or punch your borders of the bone until you reach the blue line on both sides. So that's safer. However, if you have made an opening in the sinus by any chance because of your craniotome, please don't be panicking. Don't try to coagulate. Don't try to suture. Just put some Surgicel gel foam on it and a cotton patty, and the bleeding will stop. If you are in a sitting position, then of course you have the risk of air embolism, and that's another completely different chapter which we will not discuss because that may otherwise take another half an hour. So, just one more point is that you don't try to do anything with the sinus bleeds. Just put pressure on it, but don't push in so much of Surgicel that your sinus gets blocked. If your sinus gets blocked, then it will be like a thrombosis of the sinus. So we just have to put some pressure in order to prevent the bleeding. And very soon, and then you start working somewhere else, and within a few minutes you will realize that all that bleeding would have stopped. So that is my comment for Adesh's presentation. With regard to Mathew Abraham's, yes, I fully agree. And I want to repeat my article which we wrote in volume 34 in 1985, is that the goal of acoustic neuroma surgery, the trade secret, is not the removal of the tumor, but the preservation of cranial nerves. So preserve the cranial nerves. So all your eyes and focus must be on preserving the nerves, and tumor removal is a byproduct. So if you can just imagine that strategy, you will be able to save more and more cranial nerves. So, but my question to Mathew is, if after opening the sinus, after opening the cisterna magna or your cisterns, but you still find the cerebellum grossly bulging, what would you do? If the cerebellum is not settling down in spite of letting out CSF, what is your strategy? It may not happen routinely, it may happen very rarely. But what have you?
It's not uncommon. I'll first see if the airway pressure is high or the neck has undergone torsion.
Yes.
I think that is the first thing that we have to see.
Yes. Yes.
The second thing is you can go for an EVD. You can tap the CSF above. Very likely that there may be an acute hydrocephalus being on top.
Yes.
If these two are not working and have any access to the any portion of the tumor, you can go for very aggressive rapid decompression, which usually will relieve some CSF. And if situation looks more desperate, you can actually remove part of the cerebellum.
But you just don't have access. The cerebellum bulging so much. You have no access to tumor debulking. I have faced this after 1,000 acoustics. I must say, I only faced this problem twice. But what I have done is that I have closed the brain. I have closed the dura. I don't continue with the operation because if I do it, I will only damage the patient. So usually I just say we will have to retreat and come again another day after sufficient brain relaxes. You can give mannitol, steroids, whatever you want to allow the brain to relax and then come again another day. That is, I'm sure every one of us will face this situation at least once in your life, that cerebellum bulges so badly, and in spite of all your maneuvers, you may not be able to settle it. And as you rightly said, all vestibular schwannomas are different. They are all different. And therefore, the strategy has to be modified a little bit here and there for every case. I saw you retracting, Mathew, the cerebellum. Would you prefer to use a broader blade, or would you prefer to use this kind of a blade that I saw you using?
Yeah, I use the narrows because I think wherever I have retracted, I use only the narrow blade. The broader blade ultimately gives more pressure to the entire blade. The exposure that a narrow blade is likely to give at the very site that you want to see is superior. The broader blade will have to be placed more away from your region of interest. And at a higher zoom, the broader blade does not matter. When you zoom higher, the very tip that is the only region of interest. The opinions may vary, but even if the brain is bulging, I always place a narrow blade. But the total volume of amount of retraction required is often less.
Correct. But don't you use the retractor from below upwards rather than from the lateral? From below upwards, means lifting the cerebellum up, and rather than working on the cerebellum laterally. Of course, from above downwards is banned because you will damage your petrosal vein. But from the lateral,
I understand the deeper emphasis that you meant with that. An upward and lateral retraction is always better. But once your brain is relaxed and you want to go from multiple trajectories, the initial stage, an upward and lateral distraction may be better, particularly in a larger tube. But once you have achieved significant decompression, I don't think the retraction point matters.
Right. Yes.
Once the things have started to fall, they started to crumble.
Yes. No, I'm only talking about
when you're using a narrow retractor, you can go anywhere.
Right. Okay. All right. Thank you very much, Mathew. It was a great joy looking at your surgery and your points. I fully agree with most of the things that you have said. Thank you.
It's a question box. There's a question. I think most of the questions are answered. One question to Atul Goel, sir, by Dr. Sushank. The role of, because dandy spine is important. What happens in supracerebellar approach, whether you coagulate the dandy spine or try to preserve?
This is a very beautiful question. You see, when you are coming supracerebellar and you are retracting the cerebellum down, this vein can get under traction and it can rupture. And if you are doing in a sitting position, this rupture can be a big cause of a problem. So it is better to coagulate this early in the operation, retract the cerebellum, then you can retract the cerebellum very much down. You see, when you are doing this, of course, problems have been reported following this vein in trigeminal neuralgia and things like that. But this is a very frequently done procedure, and I don't think we should really worry about coagulating and cutting the dandy vein if we have to come from supracerebellar. If we want to come from petrous apex and all those things, that is a different. But from here, you have to cut. The other thing which I want to talk about petroclival meningioma and the issue of preserving the cranial nerves is very important, that you just don't become a technician and a technical man. You have to be philosophical and work in the interest of the patient. So whenever I have to do any dissection around the facial nerve, around the sixth nerve, for a little bit prolongish time, if I am dissecting the facial nerve for 10 minutes or 15 minutes, I think I am, I try to avoid that dissection now. Of course, I used to, and I have shown in various meetings how to dissect and dissect. But if there is a little bit prolongish dissection, you avoid that dissection and leave a sleeve of tumor on the facial nerve, on the sixth nerve. Of course, you have to leave, because if you damage or move the sixth nerve more than it, you create a disaster with the eye, and this means you have lost the eye. It is worse than complete eye, cutting the optic nerve. Cutting the sixth nerve is worse than that. So it is very important that you save the sixth nerve and avoid too much dissection if it is necessary. If you can get the plane and quickly dissect, also perforators around the posterior circulation. If the perforator you have to dissect for a period of time, I think it may be not a bad idea, not a bad idea. It is necessary to not to continue dissection for longest time. So this is what I have recently, not recently, for last several years, that leaving behind tumor is not a technical or a philosophical error. Rather than taking risk is sometimes can cause a big nuisance. In acoustic tumor, you have heard me talking on acoustic tumor recently. You see, if you have heard my old lectures, how I used to try to save the eighth nerve, how I wanted to get the hearing improved, and all those things that I have been doing for last several years. But if you ask me recently, and as Dr. Turel also mentioned, more than resection of the tumor, it is the preservation of facial nerve that is mandatory. So if you have to dissect the facial nerve for more than a certain period of time, you are doing a technical mistake. Don't try to dissect don't try to tease the tumor in largest tumor for a prolonged period of time. If it is coming, sometimes it comes quite safely. On the other hand, eighth nerve dissection is much more easier than seventh nerve dissection. On the other hand, in meningiomas, facial nerve dissection is much more easier than acoustic tumor and facial nerve. So we have to know the tumor, we have to know the biology, we have to know the needs of the patient. If you damage one cranial nerve, you have damaged a lot. If you have damaged one perforator, you have completely damaged the person. Basically, as you evolve in the subject of neurosurgery, you have to learn safer and sure. Safe and sure and positive is the attitude. Radical is the thought, but safety is the means and method to achieve success. And my feeling is, no question, for acoustics, don't try to twist the facial nerve. For pictoclavial meningioma, if you have to dissect the sixth nerve for a little bit more time, that is a technical mistake. You damage sixth nerve, you're gone. You damage first one little perforator of posterior circulation, you may have a hemiplegic patient on your picture. You damage perforator around the PCOM artery, which is quite frequently on the dome of the tumor. You create a disaster. So, if you want to be safe, you have to prevent disaster. And if you want to prevent disaster, don't think that you are absolute in the business of neurosurgery. You have to be respecting the tumor, respecting the patient, and whenever it is going beyond a point, you have to leave a significant, if necessary, significant part of the tumor, but don't mess around with the cranial nerves and blood vessels. So this is my recent kind of a strategy.
Professor Atul.
Yeah.
Yes, because this is back to basic, I want to ask you basic question. That up to what extent of the clivus, the petrous tumor going down, you would go for this approach, number one. Number two, how much of the craniotomy posteriorly, up to foramen magnum, or even you would sometimes need to remove C1 also?
See,
or
as you said,
yeah,
go ahead. Hemant, go ahead.
Or only you are just letting some CSF out would make the difference?
No, you see, Hemant, first of all, Hemant, thank you for inviting me to this webinar. I enjoyed it. Actually, you will not believe how much I ran and came for this webinar. I was already getting late, but it is important for me, and that is why I thank you and Roopesh and the team. Second thing is regarding how much down you can go. You see, supracerebellar is one thing, but when the tumor is going down, after you have debulked significant part of the tumor, then you can go retrosigmoid. means in the CP angle, and work between the cranial nerves like 7th and 8th and lower cranial nerve. Of course, when the tumor goes down, you have to go down to the lower cranial nerves. On several occasions, it is necessary, like foramen magnum, going down the clival tumor, going from right the entire clival. So you have to extend the exposure. And if necessary, you have to go down and everywhere. So depending on the nature of the tumor, depending on the extent of the tumor, you don't have to continue on the supracerebellar. Once the debulk is done, the whole cerebellum becomes quite a soft, retractable structure. You retract and then come between the cranial nerves laterally. I'm not saying continue the whole operation from supracerebellar, but as an initial avenue for epidermoids, for pictoclival meningioma, it is very safe because early in the operation, trigeminal nerve can be relatively easily identified. You come and identify the tumor, debulk the tumor, learn the art of debulking the tumor, break it. After all, you know what, Hemant, you know, pictoclival tumor, meningiomas in particular, are not for, it is an ultimate of neurosurgery. It is the top end of neurosurgery. Once you get more and more and more and more experience, it is not a game of, novice and early experience and early this thing. Pictoclival meningiomas in particular, how to remove, how to debulk, how to save the arteries, how much to remove, how to remove, are all top line neurosurgical subject which has to be learned, and this has to be learned over several cases. You have to be involved in the neurosurgery theater all the time. You have to love the smell of the operation theaters. You have to love the smell of a cadaver dissection. You see, some people go and do cadaver dissection, they cover their nose because they cannot accept the smell of the cadaver. You have to enjoy the smell if you want to do it, pictoclival meningiomas, chordomas, for instance. Chordomas are a little different tumor, but meningiomas, how to remove. These are, beautiful chapters of skull-based neurosurgery.
See, Hemanth Bhartiya, you asked
Yes, sir.
about the extent of exposure of posterior fossa craniotomy. If
Yes,
you are
sir.
going to retract the cerebellum down, if you still have the bone covering it, how will you retract it? So you have to do a proper formal craniotomy like you do for any posterior fossa surgery, so that if the bone is out, only then you can push the cerebellum down. Otherwise, the cerebellum will keep hitting the...
No, my question was going up to foramen. Foramen.
Yeah. You have to go way down.
Another message, Hemant,
Yeah.
I want to give to the young neurosurgeons and evolving neurosurgeons and those who are sitting in the audience listening to this, that if you are doing many cases, it is very important that you publish your work. And if you are saying it is my approach, you show me the publication. And unless you show the publication, you cannot just say, even if you have done several years ago, and many people have done what have they done. Publications are important for everyone. If you have a little bit different idea of anything, you first publish and then talk. I think, the importance of publication, Hemant, you have to introduce in the skull-based neurosurgeons in a big way, importance of publication. Publications are not just English. It is not just English writing. You are good in English, you can write. It is not like that. It is the game of neurosurgery. It is the game of ideas. If you have an idea, you can publish. If you just want to say this and that, that is not the best way to do it. And if you have a publication, and I say this is my technique, nobody can challenge. If I say supracerebellar approach to clival chordoma is my technique, nobody can challenge. If I say interdural approach to trigeminal neuroma is my technique, nobody can challenge. So this is why nobody can challenge, because I have published and I have shown. So this is very important for young neurosurgeons to realize. We have senior neurosurgeons here, Dr. Turel and all those people, they have done it all and seen it all. But Dr. Turel himself acknowledges the importance of publication. He himself always recognizes the beauty of necessity of publications. And I want if Keki can talk about this in a few sentences.
Dr. Keki has just left, I think.
I think what Dr. Atul is saying is very right, to publish the things, because I have seen this personally also, that the first cavernoma of the trigeminal nerve, I had spoken about it in year 1998 in Japan, but I did not publish it. That was the first case of cavernoma. But after that, many have been published. So that this happens, and then you feel that you have already, means presented a paper on that. So one should publish their work. Yes, Dr. Roopesh Kumar.
Yes, sir. So one more question. The reaching the you showed beautiful cases of a middle fossa you could remove by the supracerebellar. So Dr. Mathesami was showing that he will drill the suprameatal wrist to go it into that. What is your concept and philosophy of doing that?
Yes, now this is another very important thing. You see, now if in my presentation I mentioned that if the tumor is going in the middle fossa, then you have to be really little bit careful about removal of middle fossa part from posterior fossa. Whenever the tumor, if you encounter a lot of venous bleeding while it's doing posterior fossa, I think it may be a little dangerous if you are doing in a sitting position. Like what I am saying, supracerebellar, if you are doing in sitting position and you are trying to remove cavernous sinus portion of the tumor, or working in the clivus where there is a lot of venous bleeding can be possible. So in case of venous bleeding and sitting position, it is a dangerous position to operate. So when you see that there is a possibility of a lot of venous issue, then you work in a lateral position and in a different kind of position. Like clival chordoma, supracerebellar approach, I have done one case and I had a problem of venous embolism, air embolism. So I have stopped doing tumors which are now, some tumors are in the Meckel's cave in the dural sleeve. And when you come from the posterior fossa, you can relatively easily remove. And some tumors are outside the cavernous sinus, in the middle fossa. Then you can drill the petrous apex, cut the tentorium and remove the tumor. But if you cut the superior petrosal sinus while drilling from the posterior fossa, you can have quite a significant difficulty in controlling that bleeding from the posterior fossa because your access to the superior petrosal sinus is not so great. So you have to be, here and there, and how much to remove supratentorial. For epidermoid is a different story. They are extraaxial tumors. They are in the subarachnoid spaces. You can go and work in there is no venous structure in that area, and you can do beautiful posterior fossa exposure for middle fossa tumor. So we have done several, maybe hundred, I should not say hundreds, but at least quite a number of epidermoids in the middle fossa, from posterior fossa. There, in those cases, you don't need to do suprameatal drilling and all. In general, to answer your question, I will try to avoid drilling in that area if I'm doing in sitting position. Drilling of the suprameatal triangle should be very limited because cutting of superior petrosal sinus sometimes leads to difficult bleeding, sometimes opening the cavernous sinus and getting into the venous structure of the cavernous sinus can lead to difficult bleeding and also little dangerous bleeding. So we have to be a little bit careful about the suprameatal drilling. Roopesh.
Another basic question. You showed some cases where you removed epidermoid from above the tentorium. So you always cut the tentorium to reach the because the video was truncated. It is edited video. So
Yes.
first question is how often you cut the tentorium to reach the supratentorial. The second question, if you want to cut the tent, you cut from lateral to medial or you come from the free edge towards lateral.
Yes. Now, first thing is for the middle fossa component of epidermoid tumor. You see, once you have removed the posterior fossa component in a significant manner, the brain is very, very lax and the whole tentorium is under your direct vision. And you can easily cut the tentorium.
If I can go.
Now, tentorial cutting, when you're cutting the tentorium, most important cranial nerve that can be in danger is at the edge of the tentorium, as that is the fourth nerve. So you have to first identify the fourth nerve, and then if you can identify the fourth nerve, you can cut along the edge of the tentorium. If you are having some difficulty in identifying, then leave a sleeve of tumor around the edge of tentorium, along the edge where the fourth nerve traverses, cut the tentorium and work within the tumor and start debulking the supra middle fossa part of the tumor, which is, as you know, epidermoids are very easy to debulk and then beautifully dissect. And when you dissect the middle fossa part, you will see the pituitary stalk, you will see the, if you go anterior, you will see the carotid artery, you will see all the structures, you will see the hypothalamus bulging and, pulsating, and beautiful dissection. For middle fossa part, you have to cut the tentorium 100% of time. And you have to be safe when you are cutting the tentorium for the fourth nerve, which traverses at the edge, and you can damage it if you are not careful.
Sir, Dr. Keki Turel, sir, we missed you for a short time. Dr. Atul Goel was mentioning about the importance of publication, which you stressed upon when you talked. So he wants to know your opinion on the role of publications. How important is the publication of mobile work?
Undoubtedly, everybody is not as talented as Dr. Atul Goel and nor as hungry as he is, but undoubtedly, as one of our teachers, Dr. After, used to say, publish or perish. They used to say that. But then at the same time, they said, you hold the pen and you leave the knife. So if you spend too much of your time on publishing, you will not be operating. But Dr. Atul is, of course, especially gifted because he operates very fast. So he has time enough to publish.
And it should be honest publication.
Well, I can tell you 90% of the publications are not honest. There are some articles in the journals which say that do not believe publications. They are most of the publications are fabricated. Most of the research is not real search. It's just searching again and rewriting it again. So let us not talk about that because that's very controversial.
Yeah, okay. I think we should, Roopesh, we should now conclude it is.
So I think we have overshot the time, but it was quite interesting and very thoughtful and very interesting to learn the basics again from the masters of this field. And especially, I thank all the speakers, Dr. Adesh, Dr. Mathew, Dr. Atul Goel, sir, who have accepted this in a very short notice and have done a very fabulous job as usual. And also, I thank all the panelists for today, Dr. Keki Turel, sir, and Dr. Suresh Bapu, sir, and Tripathy, sir, for joining us and enriching us his knowledge and also sharing your thoughts and views about this important topic, but very common topic. And I also thank moderators, Dr. Hemanth Bhartiya, President of Society, and Dr. Parekh for joining us. So it's a great moment again. So thank you, everybody. We will put this video in the YouTube channel of Skull-Based Society. For those who couldn't see that, you'll be able to appreciate it. So we'll have one more meeting before our annual conference, and that will be on Foramen Magnum. So till then, goodbye and thank you very much for this.
Thank you.
Thank you.